excrete more urine. But we're actually seeing it at these collecting ducts, so more water is able to leave. With decreased levels, more water stays in and is reabsorbed. With aldosterone, from the adrenal cortex, you have the tubules themselves increase the resorption of sodium. Along with that, water moves. Potassium leaves, though. And then decreased aldosterone, we have more absorption of sodium, and the potassium stays normal. Water is not reabsorbed and filtrate and is excreted. Okay? Now, any of these problems, we say the main structure, that's bed of capillaries that comes in contact with the Bowman's capsule and forms the filtrate, is, think of it just as a filter. This is, and if that filter becomes diseased or inflamed, it's not going to do its job as well. So glomerular nephritis is inflammation of the glomerulus, or the structures within the glomerulus. Now, there's a couple types, acute and chronic, depending on the onset of these. Chronic is the leading cause of chronic renal failure in the United States. Acute can be due to an infection. And if we clear the infection, we can clear up the glomerulus and the problems in the glomerulus. For chronic, some of the conditions associated with glomerular nephritis are lupus, systemic lupus, and rheumatoid arthritis because of the systemic inflammation in both, and it can affect the glomerulus and the kidneys. Now, what actually happens in glomerular nephritis? Well, we know in an infectious process what happens, but if we are not sure, we're not sure what provokes that inflammation in some cases. Sometimes it's an immune reaction, we think. And what happens is the antibodies will react with antigens, and those complexes that are formed actually get trapped in the glomerulus. Remember, those complexes are bigger than just the antibodies alone or the antigens alone. If they combine in that key and lock system, they can clog that filter, if you will. So then if you have that antigen-antibody reaction, you're going to have an inflammatory response, and then you get damage to the glomerulus itself. Scarring can cause changes in the membrane permeability at the glomerulus. And then in primary types of glomerular nephritis, something, let's say strep A, beta, strep A, beta infection, or another disease process is going to trigger this immune response. Now, there's two types. I don't want you to worry too much about them. Let's go to the next slide so you can see. Most cases of glomerular nephritis are both nephritic and nephrotic. What's the difference? Well, the easy way to think of nephritic, to remember this, think of it spelled with an I. So it's inflammation. Nephrotic is spelled with an O. And so you think open. Now let me describe what I mean by the difference. In nephritic, you have what ends up happening to this patient. This is inflammation of the glomerulus. And often it's after a strep infection. You'll have a lower glomerular filtration rate. You'll have lower glomerular permeability. You'll have fluid retention and buildup of nitrogenous waste. That makes sense. You can't filter at the glomerulus, therefore you have poor rate GFR, you have lower permeability, that filter is just clogged, that membrane. You have fluid retention because it can't be excreted, it can't get through, and then you have a buildup of the waste that would normally be excreted. In nephrotic, that ends up causing massive loss of bodily proteins. So you have increased permeability in the glomerulus. So you'll have increased permeability, massive loss of proteins in the urine. As a result, if you lose proteins in the urine, you're also losing them from the serum, right? You're losing total body. So you're going to have lower oncotic pressure. And if you have low oncotic pressure, what happens to the fluid? It moves out of the intravascular compartment and causes edema, doesn't it? Also, if you have massive loss of proteins, what are they essential for? Clotting factors. So you'll have problems with coagulation as a result. So I just want you to realize that most times you're going to have a combination of both of those processes, nephritic and nephrotic. And each patient that you see is going to be slightly different in terms of their presentation. But we just really named the list of all of the risk and the symptoms that you're going to see by thinking about fluid retention, buildup of waste products. If we combine both of these, we're going to see that the waste products are going to build up. We might see edema. We might see fluid overload. We might see potassium buildup, which we will. So overall, what you can think of with glomerulonephritis is that you're going to have loss of filtration and loss of selective permeability. So as in the grocery store, you're going to take everything off the cart, keep it in the cart, and pay for it. And then you have all of this extra food that's just going to spoil. You have all of this extra waste from the body that's just going to build up and build up and build up. So, there's a lot of signs and symptoms. We have hematuria and proteinuria. What we're going to see is blood in the urine and protein in the urine. The red blood cells are too big. They shouldn't be in the filtrate. You shouldn't have blood in your urine. Proteinuria, again, protein should not at any time be present in the urine because it's too big. Normally, that protein and red cells cannot pass through the glomerulus, the filtration there. So inflammation changes the permeability, and therefore you'll see blood and protein in the urine. And what did we say hypoproteinemia is? Low blood protein. Therefore, you're going to end up with edema. Lower oncotic pressure. You're going to see a buildup, what we call azotemia. And that's the waste products the nitrogenous waste products from the breakdown of proteins in the system, the muscles, and so forth, we will see azotemia. We'll see oliguria in glomerulonephritis. What is oliguria? Not so much urine, not enough urine. What is the amount of urine that you are sitting there producing per hour at a minimum? Who said 30? 30 cc's or mLs per hour is the minimum that any of us should be producing, regardless of your hydration status. That's the minimum. Now, you know, if you're chugging water, or if you have coffee or any other liquids, you're going to increase that. But 30 ml. So in your patients, when you're monitoring your patients, and say they have a Foley catheter, did you learn how to put in Foleys yet? Not yet. The minimum that you should be seeing coming out of that into that bag is 30 mLs per hour. Certainly more than that if the patient's getting a lot of IV fluids. So oliguria is a drop below that, below 30 mLs per hour. Edema, because of the oncotic pressure, less oncotic pressure in the vascular space, you're going to see edema forming in the tissues. As Richard said, you're going to see hypertension because you're retaining all of this extra fluid. So when we have decreased glomerular cap damage at the glomerulus, we're going to see loss of plasma proteins. That's the big one. What is that going to create? The liver is going to synthesize bad lipoproteins. Why? Because high-density lipoproteins, back to our cardiac section, high-density lipoproteins have more protein, don't they? So if there's not a lot of protein, the liver is going to produce low-density lipoproteins, the bad ones, the ones that can form atherosclerosis. Because there's not enough protein to go around, and this isn't overnight. This is in chronic disease. If you have glomerulonephritis and you can clear it up within a week or 2 weeks on antibiotics, great. But when somebody's in chronic glomerulonephritis, they're going to always have hyperlipidemia. But hyperlipidemia that's concerning because it's the bad cholesterol, the low-density lipoproteins. Who has questions about that? All right. You also are going to have, we said decrease oncotic pressure, so you're going to have fluid moving from the intravascular space to the extracellular space, and then as a result of that, that's going to activate the renin-angiotensin system because you're going to have lower volume in the vascular space. That's going to make things worse.